You know what makes a person sign a surgical consent form faster than almost anything else? Fear. Not pain, not logic, fear. The moment a specialist lowers their voice, circles a scan, and says, "We should operate," the room changes. The walls feel closer, the future feels shorter. And most people, especially after 60, do the same thing. They nod, they trust, they hope. Because what else are they supposed to do when a white coat tells them this is the safest path forward? But that quiet moment, that simple yes, can divide a life into before and after in ways no one mentions when the forms are still warm from the printer. For years, families have been told that modern surgery is cleaner, faster, smarter, and safer than ever. And in many cases, that is true. Lives are saved every day by operating teams doing extraordinary work under brutal pressure. But there is another side to the story, and if you are older, frail, exhausted, already taking a fistful of medications, or carrying illnesses that quietly wear down your reserves, that other side matters more than most people realize. Because the real danger is not always the disease itself. Sometimes it is the stress of treatment. Sometimes it is the recovery nobody explains. And sometimes the body survives the procedure but loses something precious on the way back. Dr. Marcus spent more than 20 years inside operating rooms watching this happen in real time. He saw procedures that looked technically perfect on paper lead to months of confusion, weakness, infections, broken sleep, dependence, and regret. He saw patients who were told they needed immediate action when what they actually needed was time, clarity, and a brutally honest conversation about what surgery would really cost them. Not just in dollars, in strength, in memory, in independence, in the ordinary life they assumed would still be waiting on the other side. And that is where this story begins. Not with a scandal, not with a conspiracy, with a question that sounds simple until it lands in your own chest. When a surgeon recommends an operation after 60, what are they really measuring? Are they measuring the condition they want to fix? Or are they measuring your body's ability to survive the fix itself? Those are not the same calculation, and if nobody explains the difference, you can walk into a procedure believing you are buying more life while accidentally trading away the life you still had. Here is the uncomfortable truth. Age alone does not decide outcomes. Some 78-year-olds recover like athletes, some 63-year-olds do not. The issue is not the birthday on your chart. The issue is reserve, how hard your heart already works, how quickly your kidneys clear drugs, whether your lungs rebound after anesthesia, whether your brain can tolerate inflammation, sleep disruption, pain medicine, and the shock of being cut open. Frailty is not an insult, it is a clinical reality. And once that reserve drops below a certain point, the operation you were told is routine stops being routine for you. That is why the next few minutes matter, because there are 5 types of surgery that often carry hidden dangers for older adults, especially when the decision is rushed, oversimplified, or framed as inevitable. Some of these operations save lives in exactly the right circumstances. Others are offered too casually. Others still may be technically successful and personally devastating at the same time. And one of them becomes especially dangerous precisely because nobody plans for it until the worst possible night. Before we reach that final one, you need to understand the trap that catches so many families. It usually begins with one sentence. If we don't do something now, this could get worse. That sentence may be true, but worse how? Over what timeline? With what alternatives? For what kind of patient? People hear urgency and imagine catastrophe. They do not hear nuance. They do not hear that do something might mean medication, rehab, injections, monitoring, nutrition, weight loss, smaller procedures, or simply waiting long enough to make a better decision. They hear surgery. And once that idea takes hold, fear does the rest. So let's slow everything down and look at the first operation on this list. The one that terrifies people because it sounds like the ultimate rescue, and, in the right hands, often is. Yet for the wrong body at the wrong moment, it can become the beginning of a decline nobody saw coming. Open heart surgery has saved countless lives. It has also broken more recoveries than most families are prepared for. And the hidden risk is not where most people think it is. It starts long before the first incision, with a machine, a fragile brain, and a question few patients ever think to ask. One more thing almost nobody says aloud. The body does not experience surgery as a neat solution. It experiences threat. Hormones surge, muscles waste faster in bed, appetite disappears. Sleep fragments under alarms, pain, and unfamiliar ceilings. A week in the hospital can age an older adult in ways a younger family member cannot easily imagine. That is why asking whether something can be done is only the beginning. The harder question is whether your body can pay the bill afterward without bankrupting the rest of your life. People imagine danger as the dramatic moment on the table, but for older adults, the quieter dangers often matter more. A missed appetite, a delirious night, a fall after discharge, a heart that never fully regains rhythm, a mind that takes weeks to clear. Families call these setbacks. In reality, they can become turning points. Once strength slips far enough, independence follows it. That is why the first operation on this list is not really about heroics at all. It is about whether the rescue is gentler than the crisis it is meant to prevent. And sometimes, the safest-looking option becomes the most dangerous choice for you. When people hear open heart surgery, they picture blocked arteries, skilled hands, bright lights, and a dramatic repair that restores blood flow and gives the patient a second chance. That image is powerful because sometimes it is true. For the right person, coronary bypass surgery can relieve symptoms, protect the heart, and extend life in meaningful ways. But the older the patient becomes, especially when frailty, diabetes, kidney disease, lung issues, or mild cognitive decline are already in the background, the story changes. The operation is no longer just about the heart. It becomes a full-body stress test with consequences that can echo long after the chest is closed. During traditional bypass surgery, the heart may be stopped and circulation supported by a machine that temporarily takes over the work of the heart and lungs. Surgeons understand that system well. It is not experimental, it is standard. Yet what is standard for medicine can still be punishing for an older body. Blood pressure swings, inflammation rises, tiny changes in circulation can affect the brain, kidneys, and lungs. A younger patient may absorb that storm and recover steadily. A frail patient may come through the operation alive, but emerge weaker, confused, breathless, or unable to regain the independence they had before the procedure. That is the part families often do not hear in plain language. They hear survival rates. They hear technical success. They hear that the blockage was severe and the surgery went well. Then they meet the version of recovery no brochure describes. Days on a ventilator, delirium that turns a calm parent into a frightened stranger, kidneys that never quite recover, a stroke no one predicted, weeks in rehabilitation, months of exhaustion, and in some cases, a quiet realization that the operation solved one problem by creating 3 more. Dr. Marcus remembers a patient whose family entered surgery day believing they were choosing the obvious best option. The man was 79, proud, sharp, stubborn, and still walking every morning. His heart disease was real, but so were his kidney problems and his declining stamina. Everyone focused on the blockage. Almost nobody focused on reserve. The bypass worked. Technically, it was a success, but the man spent days confused, then developed complications that stretched his hospital stay, then lost so much strength that he never returned to living independently. His family later said the hardest part was not that he had surgery. It was that nobody prepared them for the possibility that he might survive and still lose the life he recognized. This is where a crucial distinction appears. There is a difference between surviving surgery and surviving recovery. If you remember nothing else, remember that. Older adults do not only need a procedure they can technically tolerate, they need a path back afterward. If that path requires reserves the body no longer has, the recommendation must be questioned, not because surgery is bad, but because the goal is not simply to leave the operating room alive. The goal is to preserve meaningful life beyond it. That is why less invasive options matter so much. In some heart conditions, catheter-based procedures can treat the problem without opening the chest or placing the patient through the same degree of surgical trauma. Not every patient qualifies, not every condition allows it, but many people never even ask whether an alternative exists. They assume the recommendation they heard first is the only path worth discussing. That assumption can cost them dearly. And heart surgery is only the beginning, because the second operation on this list is far more common, far more casually recommended, and far more likely to be framed as the answer to a suffering millions of older adults know intimately. Back pain, stiffness, numbness, a spine that seems to age faster than the rest of the body. The promise sounds irresistible. Fix the structure, stop the pain, get your life back. But what happens when the structure is changed and the pain does not leave? What happens when hardware goes in, mobility goes down, and the part of the spine above and below the repair begins to fail under the new mechanics? That is the problem nobody appreciates until it is already too late. Because the most dangerous thing about aggressive spinal surgery is not that it always fails. It is that it can sound completely reasonable right up to the moment recovery proves otherwise. And once screws, rods, and fused levels become part of the plan, there is no easy way to undo the bargain you made for relief. And there is a psychological burden as well. Once a heart operation is recommended, declining it can feel reckless, even when careful questioning would show the situation is more nuanced. Patients worry they will seem ungrateful. Families worry they will be blamed if something later happens. So everyone drifts toward the most aggressive option because it feels morally safer. But moral comfort is not the same thing as medical fit. A good decision is not the one that looks bravest in the moment. It is the one that best matches the life the patient still wants to live. Even more unsettling, many patients are never told that recovery itself can permanently alter identity. A previously independent person may leave the hospital unable to manage medications, walk unassisted, or think with their former sharpness. Families often call this a complication, but to the patient it can feel like displacement, as if the operation solved the anatomy while rearranging the self. That possibility does not make surgery wrong. It makes honest consent impossible without discussing it. And most people do not realize how often that discussion is softened, shortened, or skipped. That is why the smartest question is not, "Can this surgery be done?" but, "What version of me is likely to come back if it is?" Families deserve that answer before the consent is signed, not after the confusion begins and everyone is forced to pretend the outcome was unforeseeable entirely. Back pain has a way of shrinking a person's world inch by inch. First, it changes how long you stand, then how far you walk, then whether you visit friends, carry groceries, sit through dinner, sleep through the night, or trust your own body in the shower. By the time many older adults meet a spine surgeon, they are not just seeking pain relief. They are grieving a life that used to feel ordinary. That grief makes people vulnerable to certainty, especially when certainty arrives in the form of scans, arrows, and a surgeon pointing to discs, narrowing, instability, degeneration, and the places where age has left visible marks. And here is the trap. Imaging can make structural change look like destiny. If something looks damaged, people naturally assume it should be repaired. But the spine is not a broken chair leg. Many older adults have dramatic-looking scans and manageable symptoms. Others suffer severely with findings that appear less impressive. Pain is real, but the relationship between what is visible and what must be surgically fixed is often far less straightforward than patients are led to believe. This matters because aggressive spinal procedures in older adults can carry heavy risks. Multi-level fusions, decompressions with instrumentation, and long operations involving blood loss and hardware may be appropriate in certain urgent cases, especially when there is progressive weakness, severe nerve compression, loss of bowel or bladder control, or structural instability that truly threatens function. But elective fusion for chronic degenerative pain is another matter entirely. The recovery can be punishing. Blood clots, infections, falls, hardware failure, pneumonia, prolonged rehabilitation, and new pain from altered mechanics are not rare footnotes. They are central to the decision. Dr. Marcus once spoke with an older woman who had been told surgery was her best remaining hope. She was 68, exhausted, and increasingly afraid that if she did nothing, she would end up bent, immobile, and dependent. She agreed to a major fusion spanning multiple levels. The operation went as planned. The pain did not disappear, it changed. Some of the old pain eased, but new pain emerged, different and sharper. Her recovery dragged. Then the segments above the fusion began to strain under forces they were never meant to absorb alone. She later said the most shocking part was not that surgery involved risk, it was that no one had clearly explained that the outcome she feared most, still hurting and less mobile than before, was possible even after everything went right. That sentence should stop every patient in their tracks, even after everything went right. Because older adults are too often sold surgical decisions as if the only variables are courage and technical skill. In reality, the body writes much of the final story. Tissues heal more slowly. Balance may already be fragile. Muscle loss can accelerate during recovery. A hospital stay can erase months of hard-earned independence. And when the procedure is elective, every one of those realities deserves the same level of attention as the MRI. There is another issue almost nobody talks about at first. Sometimes conservative treatment is not the failure people think it is. Physical therapy, targeted injections, medication adjustments, posture training, strength work, weight reduction, and slower but more strategic pain management may not sound dramatic, but they can preserve function without forcing the body through a major intervention it may never fully absorb. That does not mean avoiding surgery forever. It means not confusing an available tool with an unavoidable destiny. But if spinal surgery exposes the danger of mistaking visible damage for a clear answer, the third operation on this list goes deeper into the emotional center of decision-making. Because once the word cancer enters the room, almost every human instinct screams the same command: cut it out, remove it, do whatever it takes. That instinct is understandable. It is also precisely why some of the most consequential surgical decisions older adults ever make happen under the weight of fear, urgency, and hope colliding all at once. And sometimes the operation does remove the tumor. Sometimes the pathology report even looks like a victory. But what if the patient never gets the good years they were trying to protect? What if the body collapses under the burden of cure? What if the thing that shortens life is not the cancer itself, but the attempt to defeat it at any cost? That is where the next story becomes much harder to hear. There is also a cultural story wrapped around back surgery that keeps people moving toward the operating room. If pain has a physical location, people want a physical correction. It feels satisfying. It feels logical. It promises closure. But bodies, especially aging bodies, rarely behave like simple machines. Sometimes nerves calm only when inflammation drops. Sometimes muscles compensate better when they are trained. Sometimes fear itself magnifies pain until movement becomes part of the cure. None of that makes suffering imaginary. It means the obvious answer is not always the truest one. Another hidden problem is expectation. Older patients often believe that choosing surgery proves they are finally taking decisive action, so they endure miserable recoveries assuming the payoff must be just ahead. That belief can keep them from recognizing when the benefit is not arriving. It can also silence second thoughts before the operation, when there is still time to pause. Hope is powerful, but unexamined hope becomes leverage, and in spine care, leverage is often enough to turn uncertainty into consent long before the patient understands what the consent truly covers. That is why statistics alone can mislead. A complication rate sounds abstract until the complication is yours, the weakness is yours, the lost balance is yours, and the promised return to normal keeps moving farther away with every appointment. By then, the decision feels irreversible because, of course, it is. That is why the most persuasive promise in the room is often the one patients should examine most slowly, not embrace fastest. Cancer changes the emotional weather of a family in a single conversation. One appointment, one scan, one biopsy result, and suddenly everyone is speaking in a new tense. Not what was, not what is, what must happen now. The impulse is immediate and deeply human. Find the tumor, remove it, move fast, do not give it time. For some patients, that instinct saves life. For others, especially older adults with limited reserve, the decision is more complicated than anyone wants it to be. Major cancer surgery is not just about whether the tumor can be removed. It is about whether the patient can survive the trauma of removal and still gain something worth having afterward. That sounds harsh until you sit with the reality. Some operations are among the most demanding in medicine. They can last many hours, involve major blood shifts, multiple organ systems, complex reconstruction, long hospital stays, and a recovery so physically draining that even a successful procedure may leave the patient too weakened to enjoy the time it was meant to buy. Dr. Marcus recalls a family who came to him after hearing what sounded on the surface like hopeful news. The cancer appeared operable. The surgeons believed they could remove it. Everyone clung to that word, operable, as if it were a promise. But the patient was 81, already losing weight, living with heart disease, reduced kidney function, and a level of frailty that had been obvious for months to anyone watching him stand, walk, or recover from ordinary illness. The tumor mattered. So did the body carrying it. One without the other was not the real equation. This is where older adults are often failed by language. Operable does not mean wise. Resectable does not mean beneficial. Technically possible does not mean personally right. When fear enters the room, nuance becomes almost unbearable. And yet nuance is exactly what determines whether treatment serves the patient or simply serves the disease. If the likely result of a major operation is prolonged intensive care, complications, repeated procedures, delirium, infections, and a life that narrows instead of expands, then the conversation must widen beyond surgery alone. That does not mean surrender. It means asking a harder question than most people are prepared to ask. Not, can you remove it, but what kind of life is realistically left if you do? Radiation, targeted therapy, immune treatment, symptom control, or carefully chosen observation may sound less heroic than a major resection, but heroism is not the point. The point is aligning treatment with the life the patient values, the time the patient may actually gain, and the body the patient truly has. This is also where guilt becomes dangerous. Families often feel that if they do not pursue the biggest intervention available, they are giving up. Patients feel they must be fighters. Surgeons feel pressure not to sound defeatist. But there is nothing weak about choosing a path that preserves clarity, comfort, mobility, and meaningful time over one that pursues maximal removal at the cost of everything else. Sometimes the most courageous medical decision is refusing to confuse action with benefit. And yet, the next category of surgery proves that even operations with genuinely excellent reputations can become risky when timing, preparation, and overall health are ignored. Joint replacements have transformed lives. For many older adults, a new hip or knee means walking again, sleeping again, returning to errands, stairs, hobbies, and the simple dignity of movement without grinding pain. In the right patient, these procedures are modern medicine at its best. But elective does not mean harmless. Planned does not mean low risk. When an older adult has multiple major illnesses, poor circulation, obesity, uncontrolled diabetes, heart disease, severe deconditioning, or breathing problems, the question changes. The issue is not whether joint replacement is a good surgery in general, it is whether this body, on this date, in this condition, is ready to withstand it. Blood clots can form, infections can spread, pneumonia can follow immobility, the wound can heal slowly, rehab can stall before it begins, and a surgery intended to restore independence can delay it for months or threaten it entirely. Which raises a dangerous misunderstanding few people notice until the schedule is already set. When a procedure is elective, patients often assume that means they are safe to proceed. But elective only means it is not an emergency. It does not mean your body is optimized. It does not mean your risk is acceptable. It does not mean the calendar matters more than preparation. And what comes next may be the difference between a successful transformation and a complication spiral nobody saw coming. And if that sounds abstract, think about the difference between extending existence and preserving living. One can happen without the other. A patient may technically gain months, yet spend them in hospitals, rehabilitation centers, or a haze of weakness and complications. Another may choose a less invasive path and spend that same time at home, lucid, present, and able to enjoy the people around them. Those are not equal outcomes simply because both fit under the broad label of treatment. That is why language matters so much in oncology. If the conversation centers only on removing disease, patients may never realize they are allowed to weigh cognition, stamina, independence, and time at home as outcomes equal in importance to tumor control. Once those values enter the room, treatment choices often look very different. The frightening part is not that doctors hide this on purpose. It is that momentum, training, and fear can narrow the frame so completely that no one notices the patient's real priorities have disappeared from view. Once that frame widens, some patients still choose surgery, and wisely so. Others recognize that preserving ordinary mornings, familiar faces, and a body they can still inhabit comfortably matters more than pursuing the most aggressive option available simply because it exists. And that realization can completely change what courage looks like later today. There is a word many older patients never hear until the best hospitals insist on it, and once you understand it, you start seeing surgery differently. Prehabilitation. Not rehabilitation after the operation, but preparation before it. Building strength, improving nutrition, tightening blood sugar control, stabilizing blood pressure, evaluating medications, increasing mobility, sometimes reducing weight, and improving lung function before the first incision is ever made. It sounds almost too sensible, which is exactly why so many people are shocked it is not treated as standard everywhere. Think about what an operation really is. It is controlled injury in service of a goal. Even a beneficial surgery asks the body to bleed, inflame, repair, adapt, and rebuild. If the body enters that challenge exhausted, undernourished, sedentary, or medically unstable, recovery does not begin on the day after surgery. It begins in the weeks before it. And when those weeks are wasted, the price often appears later, in complications that get blamed on bad luck instead of predictable vulnerability. Dr. Marcus saw this pattern repeatedly with joint replacements in older adults who were suffering enough to want immediate relief. A man in his late 70s with severe knee arthritis was desperate to walk without pain. He also had uncontrolled diabetes, a history of blood clots, and shortness of breath after minimal exertion. The temptation was obvious. Schedule the operation, replace the knee, end the misery. But a wiser team paused. They adjusted medications, improved his glucose control, worked on strength and breathing, coordinated vascular prevention, and delayed the surgery until his body had a fairer chance. The waiting felt frustrating. The outcome was dramatically better. That waiting is something many patients resist because pain creates urgency. But if you are over 60, urgency should never be confused with readiness. The body keeps score long before the surgeon arrives. Every cigarette, every sleepless week, every skipped meal, every drop in muscle mass, every uncontrolled chronic condition affects what happens after anesthesia. And the danger is not just in planned operations. It becomes even more brutal when there is no time to prepare at all. Emergency abdominal surgery is different from every other category on this list because people do not choose it in the calm light of a clinic visit. It erupts. A perforation, internal bleeding, a bowel obstruction turning critical, a ruptured appendix, severe ischemia. The family is frightened, the patient is in distress, and decisions are made in hallways, at night, under pressure, often with only fragments of information. That is exactly why understanding the risk beforehand matters so much. Older adults facing emergency abdominal operations carry some of the highest surgical danger of all, not because the surgeons are careless, but because the body is being attacked on multiple fronts at once: pain, infection, inflammation, dehydration, shock, anesthesia, blood pressure instability, organ stress. In a younger body, the system may absorb the hit. In an older, frailer one, the response can spiral into cascading failure. Kidneys falter, lungs struggle, the heart strains, the brain clouds. One complication triggers another, and suddenly the question is no longer whether the procedure fixed the original problem. It is whether the patient can survive the chain reaction it unleashed. This is why seemingly small symptoms deserve respect long before they become dramatic. Persistent bloating, new constipation, unexplained abdominal pain, vomiting, distension, changes in appetite, a subtle decline in energy paired with digestive changes. Too many families wait because they hope it will pass, or because the patient does not want to make a fuss. But catching abdominal problems early can convert a midnight emergency into a controlled daytime decision, and that difference can save far more than time. There is one more reason emergency abdominal surgery belongs here, and it has almost nothing to do with anatomy. It has to do with family conversations that should happen before crisis. What matters more to you? Length of life at any cost, or a life that still includes recognition, comfort, and dignity? What outcomes would you accept? What outcomes would you not? These are painful questions, but asking them in advance is an act of protection. It keeps loved ones from guessing in fluorescent corridors while fear drowns out judgment. And yet, even after everything you have heard, one final mistake can undo all of it. People think the solution is simply to distrust surgery. It is not. The real solution is learning how to ask the questions that expose whether a recommendation fits your body, your risks, your values, and your future. And the first of those questions seems almost innocent until you hear what the honest answer can reveal. The cruelest part of emergencies is that they expose every weakness the body has been hiding. A person can look stable at home while slowly losing muscle, resilience, and reserve. Then one sudden abdominal catastrophe strips away that illusion in hours. Families are left asking how things changed so fast. In truth, they changed slowly first, then all at once. And that is why the final lesson in this story is not about rejecting operations. It is about learning how to think clearly before fear takes over the room. Prevention also matters here in a broader sense. Small daily choices can reduce the chance that a future emergency becomes catastrophic. Treating constipation seriously, following up on unexplained pain, staying hydrated, building strength, reviewing medications, and refusing to normalize every new symptom as just age. Older adults are often told to avoid overreacting. The greater danger is underreacting until the body has no runway left. By then, the decision is no longer between good options. It is between damage control and survival itself. That is why preparation, vigilance, and family honesty matter so much before crisis arrives. They do not guarantee safety, but they can prevent chaos from making the decision for you. Those conversations buy clarity when clarity is hardest to find under pressure. And that preparation can save lives before anyone sees the crisis. If you are ever told you need a major operation after 60, the most powerful thing you can do is not panic, not agree instantly, and not assume the recommendation in front of you is the full story. Ask questions. Not polite little questions designed to reassure the room. Real questions. Questions strong enough to slow down momentum and force clarity into a process that often moves too fast for the people most affected by it. Because a surgical recommendation is not a verdict. It is the beginning of a negotiation between a medical problem and the body that must carry the consequences of solving it. The first question is simple and often transformative. What happens if I do nothing right now? Not forever, right now. Days, weeks, months? Is the danger immediate, or is there room to think, get stronger, gather more opinions, and compare alternatives? Many patients never ask this because they fear the answer. But sometimes the answer gives them the one thing fear tried to steal first: time. Time to optimize health, time to speak with family, time to decide from clarity rather than pressure. The second question matters just as much. Is there a less invasive option? Medicine changes quickly, but many people still carry an outdated picture of treatment in their heads. Catheter-based interventions, endoscopic procedures, targeted therapies, smaller operations, staged approaches, and non-operative management strategies may all exist depending on the condition. Not every patient qualifies. Not every alternative is better. But if nobody asks, the conversation may remain trapped inside the largest possible intervention simply because it is familiar to the person recommending it. The third question cuts to the heart of what older adults actually live through. What does recovery realistically look like for someone exactly like me? Not the average patient, not the ideal candidate, me. My heart, my lungs, my kidneys, my medications, my home setup, my support system, my ability to climb stairs, manage confusion, tolerate physical therapy, or survive a week of poor sleep and pain medicine. Vague optimism is not enough. Specifics matter. If a team cannot describe recovery honestly, they are not describing the whole treatment. And then comes the question many patients hesitate to ask because it feels personal. What is your complication rate in patients my age with my risk profile? Experienced surgeons track outcomes. Good teams respect the question. Medicine is full of statistics, but your decision is not being made by a national average. It is being made by a real team with real habits, real communication, real protocols, and real numbers. If the answer feels evasive, that itself tells you something important. Dr. Marcus once spent 40 minutes with a retired engineer who had already heard the same recommendation 3 times from 3 different specialists. Open surgery, strong advice, clear urgency. But the man was not only evaluating his artery, he was evaluating the future he might lose. His wife had undergone a major operation years earlier and survived, yet never fully returned to herself. He had watched recovery become dependence and feared that outcome more than the disease itself. So instead of treating him like a box to check before scheduling, Dr. Marcus reviewed his frailty, kidney function, symptom pattern, and overall risk. Together they examined a non-surgical plan involving medication and structured rehabilitation. The man chose that path. Years later, he was still walking, still thinking clearly, still living a life he recognized. That story is not proof that surgery is wrong. It is proof that choice matters. Surgery saves lives every single day. So do careful refusals. So do second opinions. So do delays that allow the body to get stronger. So do conversations honest enough to separate technical success from meaningful recovery. The danger begins when people treat the first recommendation they hear as destiny. So remember the 5 categories that deserve special caution in older adults: open heart surgery in frail patients, aggressive spinal procedures for chronic degenerative pain, major cancer resections when reserve is low, elective joint replacement in medically unstable bodies, and emergency abdominal surgery where early recognition and prior family discussions can change everything. None of this is an argument for fear. It is an argument for informed courage.